Good morning, everyone, and welcome to our in-person meeting of the Kansas Rural Health Innovation Alliance. I just wanted to welcome everyone to our Learning Center space at KHI. I'm Sheena. You've all seen me virtually, but it's great to see you in person. A few housekeeping items. Today we'll be discussing in person, getting feedback on the draft application for the Rural Health Transformation Plan for Kansas. A couple of items to note, we do have a few virtual attendees joining us due to their rurality, so we wanted to make sure they had a chance to participate. So when we're in the main room and asking questions, we do ask you to use the mics that are located at each of your tables. That's one comment. And then we invite you, we do have a packed agenda, but please take care of your personal needs. Right outside these doors and to the right, you'll find restrooms, coffee, tea, and other needs that you may need to take care of. Feel free to get up and take care of those as we progress through the agenda. So, all right, well, welcome. We're going to go ahead and get started to keep us on time and on track. I will go ahead and turn it over to Secretary Stanek and Secretary Howard to welcome us for today's meeting.
Oh, okay. Sorry about that. I have to be on screen. Well, welcome. We won't take much time this morning. On behalf of KDADS and KDHE, thanks again for being here. Welcoming all of you to the in-person meeting. Good to see faces, and sorry for those that are online. We were really pleased with the progress that we made last week. We hope you'll agree with the two virtual meetings actually that have taken place. You'll see this is like an ongoing developmental process, and I hope things became more clear after some of the objectives and initiatives were outlined. And then I hope you had a chance to review, sorry, it's Monday, the materials that were sent out today. They'll all be gone over in great detail by Marty and team. I want to also again thank the KU Collaborative and KHI for hosting and their agility in navigating and turning the process around for us so we can get that application ready and going as we develop our strategies, which have to be outlined with a lot of detail. This is powered by you. We have some limitations, obviously, in the CMS application, but you are governor appointed, and you should be proud that you're here to hopefully get a roadmap ready for Kansas and representing the voices in the Kansas community. So with that, I will have Secretary Howard talk about what's next. Thank you.
Thanks, Janet. It is great to see everybody in person and not over a screen. It's really exciting to be here. What a great opportunity we have in front of us as a state. And today, we'll be reviewing all 5 initiatives for the transformation application, along with the related programs and projects under each one. So the whole breadth and depth as we think about that. So the goal today really is to gather your input and to gather your structured feedback. We want to do something as we think about the initiatives, right? We want to make sure, and keep this in mind as we're doing the work today, we want to make sure they're innovative. We want to make sure they're achievable. And most importantly, that they have the real potential to make a transformative difference for rural Kansas. The draft we'll review today was developed by our fantastic application review team and development team, and we are so excited. But your feedback is going to be key to really strengthening that and finalizing that draft. So that's kind of the core of the work today. For those joining us by live stream, we also welcome questions and feedback. Those can be sent to kdhe.info@ks.gov. So timeline and next steps, we've talked about this before. This continues to be a very fast moving process. What's the date today? Anybody know the date today? The 20th. You know the date. You know the date, the days and the hours, I imagine. So again, after today's discussion, the application development team will be finalizing that. That will include the interagency task force and the CARE collaborative team. The draft will get refined between today and November 3rd, incorporating the feedback that you share. Application will be submitted on November 5th. So this is the last formal opportunity as an alliance to shape the content. So I hope you can stay engaged, stay constructive, stay focused on what we're trying to achieve here. Also, later today, we'll be sharing a draft letter of support that we'll be asking alliance members to sign as a part of the application process. And we hope that you will happily do that. It's really important that we're able to show the engagement of a wide array of stakeholders as we submit this. That's a really important part of the NOFO. So again, thanks for your leadership, your engagement, your collaboration in this process. We're not just preparing an application here, we're investing in the long-term future of health in rural Kansas. So again, thank you for your part in this, and I'll turn this over to Sheena to kick us off with more details on the day.
We'll dance too. All right, thank you, secretaries, for welcoming us. I'll get us oriented to our agenda. We will have some time and going over the agenda, the objectives for our day and our time together. Then we will hear from the application development team. Marty will go over the cooperative agreement process with CMS. And then we will begin our walkthrough of the plan. We will do that before we break for lunch. Yay. And then we'll finalize the last initiatives we'll walk through after lunch. We'll share and discuss what governance and management looks like for the Alliance. That's when we'll review the draft letter of support. And then we will discuss key takeaways and next steps and adjourn. As Secretary Howard mentioned, today we'll review the application content and provide feedback. You all will suggest refinements and identify any missing elements that you still feel are important to transform rural health in Kansas, and identify which projects have the potential to be the most transformative and innovative for rural health in Kansas that will guide the application team as they finalize the plan. All right, I will go ahead and turn it over to Marty.
I like podiums, sorry. Will this work? Okay. All right, 14 pages done. That's the good news out of 60. Obviously a ways to go. Our intent is to have a draft of project narrative by Friday COB. That's obviously dependent on the feedback from this group. We are working from a draft outline of the initiatives and the programs and projects under each initiatives. But I'm here to talk about guardrails for our conversation. Appreciate that we are effectively taking a year-long planning process and condensing it to 6 weeks. And if I had a piece of advice for Congress, like they'd listen to me, but I would have said, please give us at least 6 months and some funds to develop this application so it's truly reflective of state needs. But instead, we have a very short time frame in which to submit the final application with the initiatives. In addition, we have a set of guardrails we have to adhere to tied to the cooperative agreement. So this is not a grant program. This is not simply CMS providing funds to the state to move forward in implementing what was detailed in its application. Instead, the application will be submitted on November 5th. We expect the phone calls will begin the following week between CMS and our assigned reviewer or reviewers and the application development team, because it is a negotiation between CMS and the state as to what will be within the transformation plan and what will come out. And certainly appreciate CMS is balancing the demands of 50 applications. And so it is not our application does not stand alone on its merits. It always will stand in comparison to the other applications submitted. And certainly during that negotiation period, the team will do its best to ensure maximum funding for the initiatives that have been developed by this team. Expect many of you will receive phone calls or panicked emails during that period of time as we refine initiatives, move funding, hopefully increase funding for certain projects as well. Remember, every state is working from a $200 million budget, whether that's Texas that has the most rural hospitals, or states that literally have no rural hospitals, and very few counties even designated rural. So everyone is struggling within these same confines. There are also restrictions on the percentage of funds that can be expended in certain areas. And we are now in the process of CMS, which is operating under a government shutdown, by the way, publishing FAQs informally, forwarding them to the secretaries for the most part, where they're defining out the criteria previously identified in the notice of funding opportunity. So, for example, they are taking a very aggressive view of using funds to replace what is currently a reimbursable service. And so we have to look critically at any funds we've associated with any particular program or project that potentially is reimbursable by a payer. And that's any payer, whether it's a commercial payer, a Medicaid, state Medicaid program, Medicare, a Medicare Advantage plan. We'll have to percentage out what we anticipate being reimbursable. So those are the confines we're trying to ensure that the budget stays in the correct lanes. There is, for example, the same issue of paying for what's currently reimbursable and the limits that are placed on, I'm saying this wrong, I apologize. There's a second limit we deal with, which is payment for clinical services. So even if you're paying for a service that is not reimbursable, there's still a cap on the percentage of the total budget that can be used for such purposes, which is 15%, right, Jody? Jody's the numbers girl, okay? You have a number, you go to Jody. If you have a concept, you come to me. If you need anything, go to Dr. Moser. That's the way we look at it. But that 15% then includes any type of pay for performance monies. So if you are trying to incentivize rural providers to adopt clinical protocol and you're going to provide incentives in the form of additional payments to them, even if that money is not running through a payer, they consider that a payment for clinical services. And so we're working within the 15% cap there. Why am I reviewing all of this? Because this has informed what has been included in the draft initiatives that you received over the weekend. And again, apologize we could not get those to you sooner, but it's a matter of balancing that budget that informs the scope of the different initiatives. At the end of the day, when the application is approved by CMS, when CMS tells us the elements of the fund that are being funded, so excuse me, the elements of the plan that are being funded, there is then a thing called a cooperative agreement between the state and between CMS, and that restricts the way in which CMS will allow the state to expend those funds. So this is, again, if a particular program or project has not been included in the plan, there will be a process through the 5-year term of the contract to add additional projects and programs, but it's not going to be easy. And they say very directly, we are looking for a meritorious plan across the scope of 5 years. And we anticipate that the quality of your plan will be such that you do not need to add additional programs and projects over the 5 years. So we certainly want to be inclusive to all of those programs and projects that are innovative and transformative. But at the same time, we appreciate at some point you dilute the quality of the plan by having too many ornaments on the Christmas tree. So that's the balance we're attempting to hit between it. And that's what we're looking for you today to help us do, is prioritize these initiatives in terms of their transformative impact and their practical application. And critically important going forward is measurable results. Because yes, they're going to give us an amount we're awarded in year one, and a promise that if you do a good job, you get funding in years 2 through 5. But if we cannot produce results on the metrics, the performance metrics that we identify in the plan, we lose money. That money becomes then unobligated, potentially available in other years to other states. So the competition we're feeling now with the 49 other states is just going to continue through this 5-year period. Because if Missouri does a bad job, right, then monies that they were potentially budgeted for, right? So they had a $250 million budget for the next fiscal year, 2027. And CMS determines that they didn't get far enough in their metrics for FY26. CMS will withhold a portion of the funds tied to specific initiatives. And then those monies are unobligated. CMS still has to spend that money under congressional mandate. And so those funds end up being redistributed to other states that are doing well on their metrics. So again, we want to set ourselves up for success. And that's another critical need on the part of the application team from you, is help us identify those metrics. Help us identify the data sources for those metrics. Help us identify where the gaps are to get to a measurable result. Because you will need to include in the budget, in the administrative component of the budget, dollars to develop that data, dollars to collect that data, dollars to analyze that data, because that's the key to more money moving forward. So those are our parameters. Again, CMS published an updated FAQ on Friday. Is that when we got that one? On Friday, so there's a few more complications. Tomorrow and Wednesday, they are holding office hours, 1-hour office hours, which are open Q&A by the states and their application teams. So this may all change even more as they have that opportunity to clarify any guidance they've given up to this date. If any of you are possibly laboring under the very false impression that the government shutdown is going to delay the date of this application, they have said repeatedly it will all be due still on November 5th. So take no comfort there, but do appreciate it does place some limitations on the guidance process. Any questions anyone has on the application, the process, any of that? Really? Y'all get it? I have several personally, but
I'll ask one. I'll
Good.
break the ice. So Marty, do we have a sense, and maybe you don't know yet, if a subsequent year, Kansas or some other state, there's more funds available, would there be an opportunity then to add, would it just be spend more on all the stuff that's already approved, or would you be able to perhaps add things that weren't not add new projects, but fund things that didn't get funded originally? How do you spend more money
again,
that's approved?
that's the beauty of the cooperative agreement, why it's not a grant. Because the cooperative agreement is an ongoing conversation between CMS and the state as to how funds that have been budgeted to that state can be spent. And so if we had, say, 300 million, my target, I'm not saying that out loud, 300 million for FY26, and we end up with 340 million for FY27, there would be a process engaging with the program manager, Secretary Stanek, on how those monies would be spent. So again, this group, you all get used to seeing each other, both virtually and in person, because the intention is to keep the alliance meeting on at least a quarterly basis going forward for this purpose, to explain, here's how implementation is going, here's where we're experiencing issues, here we're having data challenges, but then also here's our engagement with CMS, what their feedback is, what our additional opportunities would be. That would, when we would want to engage the stakeholders in making that additional planning going forward.
do want to clarify the latest FAQs, which I looked again till about midnight last night, did clarify that there is additional funding that can be reallocated, can be moved between projects, et cetera, but you cannot just add a brand new initiative through the process. Now, my hope would be, and one of the questions we'll ask over the course of this week is, can we increase the funding pools that would allow for those new initiatives that hadn't been surfaced today by November 5th to still have a path forward 3 years from now when something we wasn't even in, in the thinking today. And so that would be part of that negotiation is could we potentially extend the funding pools? They were very clear in the FAQ, you can't just add a brand new initiative out of nowhere.
No. So to those funding pools, Jody, we have in the proposed draft, we have projects that extend over all 5 years. And as the project grows, the budget grows because you have a greater number of providers involved. You've increased the scope to new counties and the like. So there's several instances where the budget would say start at 7, and by the end of the process, it's up to 15 million. To account for that, appreciating we've got initiatives that are going to cost more in the out years, but we still have to budget at 200 million. What we've done is most of those funds that we discussed, like the strategic regional partnership fund, which I'm not calling by the right name, those funds are limited to the first 2.5 years for the most part. So that was an example of where you'd want to put additional dollars in, because those are intended, to be not necessarily a statewide impact, but critically important to certain regions as they're moving forward in their transformative journey. Anyone else? Anything? Thank you, Carrie. Okay, then Sheena, back to you.
Okay, thank you. All right, so now we're going to begin our walkthrough of the plan. We are going to dedicate the first half of the walkthrough to going through initiatives 1 and 2. So we will present the initiatives, present information, have some time to hear about what is included in the initiatives 1 and 2. Then you'll have some time for questions and answers. And then we will have breakout discussions that will be facilitated by KHI staff, by members of the application development team, and also others that will be walking around and answering questions as you discuss in the breakout. In your packets, you have a few items I wanted to draw your attention to. You'll have the objectives and agenda. So if you're kind of curious about where we're moving through the day, you can find it there. And then you have a guided discussion guide. And so as you're hearing about the initiatives, feel free to take notes or jot down any questions you might have. And then you will have some time before we go into breakouts to address any of those. And then additionally, it will have instructions and questions that we'll be discussing during the breakouts. So you'll have some time to kind of think as you're hearing about the initiatives and start to jot down any thoughts you have. Those, we are going to ask you to submit those to us at the end of the day so that we can quickly turn around that feedback to the application development team as they finalize the draft. And that ensures, since everyone won't get to participate in every single breakout discussion, that ensures that everyone has an opportunity to weigh in on every initiative. Any questions about the process for today? Okay, well, we can go ahead and get started. I went through that really fast. Sorry about that. All right, I'm going to turn it back over to Marty and team to walk us through our first initiative.
Sorry. Thank you for including this one, Sheena. There was just a few emails exchanged this weekend, just a few. But this was one of I wanted to make sure we had this available for everyone. Because remember, we spoke last week about the dual purpose of the application, that the factors that are presented as part of the initiatives serve 2 purposes. These are the factors on which the initiatives will be scored. And as you'll recall, about 35% of the total score for workload funding is tied to these initiatives. So they're looking for the quality of our initiative across these 10 factors, but then also the factors are providing the restrictions on how the dollars can be spent. So any dollars that are included in our state's plan, we need to be able to point to one of these 10 factors. Again, that's been a criteria that has been applied from the beginning of the review of what the plan would include. I just want to review these briefly with you all so we can appreciate why certain things are in, why certain things are potentially beyond the reach of the scope of the plan. And again, these are for the most part weighted equally, although there are two of these factors that also have a state-based initiative component to them, and those are separate. And we've talked about the state-based initiatives include the school districts required to use the presidential fitness test, no restrictions on long-term, short-term insurance products and the like, but those are separate. We're focused in on our purposes are these 10. Population health clinical infrastructure, relatively self-explanatory, but how are you building capabilities within the rural health delivery network to be able to effectively manage populations, which of course is the building block for transitioning to value-based care away from strict fee-for-service reimbursement. Second is health and lifestyle. This is the true MAHA component of our plan. This is focusing on how do we provide both primary and secondary preventative services. Primary means you never get sick, you stay healthy, you have good health outcomes, you report many healthy days a month. Secondary is I've been diagnosed with something, but I'm going to prevent it from getting worse. So what components of our initiatives are going to be reinforcing good health as opposed to simply treating chronic conditions, obviously spending the most money possible there. Number 3 are rural provider strategic partnerships. Underlying this approach from CMS is that if each rural provider functions as an island, then you have a disjointed continuum of care. And the result of that is higher costs, but also folks getting lost in the cracks in the system and their conditions worsening. So how can we develop a regional approach to care so that primary care is accessible in the local community, readily available, and that there are relationships from those smaller rural communities to larger facilities at which specialist services can be furnished, whether that's telehealth connections, clinics in the local communities, adherence to consistent evidence-based practices. All of that would be encompassed within those rural provider strategic partnerships. It also has a component towards the operations of those hospitals. So can we leverage operating costs by sharing services across a region? So for example, could we have a centralized back office center that serves multiple providers within a region? So that's what we're getting there there. So improve quality by coordination, lower costs by sharing costs, lowering expense by sharing costs. Number 4 is EMS, which is a shorthand, and that's the terminology they use, EMS, but it's all things transport. So how do we, as part of that regional approach to care, how do we ensure folks are appropriately transported to the next level of care? And how do we ensure that they are going to the right place? So again, back to that idea of evidence-based practice, where a particular condition is managed in a certain way locally, and there are defined referral patterns up to other locations. Am I getting too far from the mic? I'm getting too far from the mic. Okay. Number 5 is talent recruitment. Again, that's building a strong rural workforce. This is one of those areas where the FAQs have been very strict in their interpretation of how the dollars can be spent. Like we think of rural recruitment, one of the first thing many of us go to is loan repayment. This is a very simple way of identifying an individual who potentially would come to a rural community in exchange for debt forgiveness. We can't use money for that. It's not 100% clear if you can actually use the money for scholarships. We think so, as we're reading between the lines, but they do not. They say, no, you cannot loan money. No, you cannot forgive indebtedness, but they don't do the next step and say, yes, you can provide scholarships. So we're hoping that's something that is clarified in next week's, that'd be tomorrow's Q&A with the agencies. But there is here, this is the whole entire workforce they want us to address, from physicians to non-physician practitioners to allied health to nurses to medical assistants to leadership within rural providers, but also early on career exploration. So getting folks, the middle schoolers interested in coming into healthcare. So that all of that is with that in that talent recruitment category. Yes, please do.
So obviously, when we talk about workforce, recruitment is one half of it, retention's the other half. So this is really specifically just focused on recruitment. It's pretty silent on retention.
No, I am silent on retention. My mistake. Yes, this also includes retention.
Okay.
Yes, this does include retention. My bad. But yeah, they just use the term talent recruitment for the factor. But when you read the factor details, it does include retention. Thank you, Chad. Keep me honest. Medicaid provider payment incentives. Again, this is definitely a in progress component of an initiative, but this is building into the state Medicaid program an incentive structure beyond just straight fee-for-service reimbursement. Obviously complicated with the relationship with the MCOs and their contractual obligations to the state, but maneuvering through that process to ensure that there are opportunities for providers who provide excellent, well-coordinated care are rewarded for that as part of care for Medicaid beneficiaries. Next up is individuals dually eligible for Medicare and Medicaid. Again, closely related, but this is the emphasis on having this particular population, which of course is the most expensive population in the entire healthcare spectrum, but getting these folks to what they refer to as integrated care plans. That typically falls in two categories. That's the PACE program to keep people in their homes away from institutional care. And then it's Medicare Advantage plans that have specialized criteria, programming, benefits that are built into those programs. D-SNP is the most common here in Kansas. Given that Medicare Advantage has not many friends in the provider community, they say that diplomatically enough, our emphasis is on PACE as we approach this, but also developing up within traditional Medicare processes to identify these individuals and provide more aggressive care management services, a higher level of care management services for that population. Remote care services is any way you deliver care other than face-to-face. So that emphasis on telehealth, remote monitoring, any type of service of that realm falls into remote care. Data infrastructure is our ability to collect and share data for proper management of patient populations. So think of this as a specific call out to number one, which is that population health infrastructure. Obviously, being able to have data available to treat a patient longitudinally, critically important. Still a dream that we're moving towards. How can we reinforce and make that dream come true? And finally, emphasis on consumer-facing technology. So again, there's a very strong underpinning throughout the NOFO of technology being a primary driver for transformation in rural healthcare delivery, both on the provider side, but importantly, getting technology in consumers' hands, obviously easy to use, accessible technology to consumers to help them manage their health as well. And you'll see as we start going through Initiative 1, which is where we're headed right now, that we've built in the draft several types of different consumer-facing tech to help on that first initiative, which is primary care. Okay, so there's the factor. Any question on the factors? Dr. Mosier or Jody, did I misrepresent any of that? My honest brokers, please. Okay, great. Okay, as you recall from last Thursday's discussion, 5 initiatives. The 5 initiatives are tied to the 5 elements of our mission statement. The 5 elements of our mission statement are derived directly from the strategic goals identified by CMS in the Notice of Funding Opportunity for the Rural Health Transformation Program. So the first initiative, oops, sorry, I gotta look up my, is expanding primary and secondary prevention programs. So how are we going to keep this population healthy? Our objective here is that we're going to have meaningful reductions in chronic disease rates and also avoidable hospitalizations for complications relating to chronic disease. Why are those our objectives? This is our attempt, again, to identify a way to measure progress. I'm the first to admit, and I'm sure everyone at KHI here will tell you it's true, it's very difficult to see movement in chronic disease rates. It takes time to turn that ship. It takes time to get that data collected. So we realize there's an inherent limitation in our ability to demonstrate progress, particularly in the short term. What we can do to demonstrate progress. I am really bad about that, aren't I? Okay. You should give me a little headset, right? But what we can do is demonstrate processes for collecting that data, right? And setting targets during those first early years for the specific chronic conditions that are selected. Why avoidable hospitalizations for complications related to chronic disease? That is our best available measure of whether we're managing individuals with chronic disease appropriately. So fewer people going into the hospital for a complication relating to diabetes or relating to hypertension. Those are well-developed measures over the last decade of data reported by hospitals that can be compared on a nationwide basis. So that's why that shows up as a specific objective. So under this initiative to improve primary and secondary prevention, we end up with 7 programs. So a program is a specific set of work to be accomplished to feed the initiative. There are several of these programs that are included under Initiative 1 that also have projects under them. So they're a component part of a larger program. So what we've tried to do is group similar work together so that it's well coordinated and it's feeding to the same objectives. Okay. At this point, I am going to stop talking and ask Jody to talk about the Accountable Food as Medicine plus Community Health Workers component. I'm going to get a chair.
So before we jump right into the discussion of accountable food as medicine, Sheena asked me to jump back and talk a bit about the budget. And so giving you just a preliminary perspective of where we are today on year 1. And as Marty was describing, subsequent years of budget are an extension of the initiatives that we'll talk about in year 1. So we launch a program, we add more clinics, we add more students, we add more sites, that budget grows exponentially. And I will tell you right now, while we are slightly under in year one of that $200 million target, we are over in every other year of the budget right now. And so the process that we're going through in this budget is to go back to those who have submitted and say, okay, where might there be an opportunity to reduce duplication? Where might there be an opportunity to say, we're deploying a technology and we spread it out over the 5 years, but can it perhaps be a year one investment with an appropriate agreement that holds your vendor accountable, but can be included in year one as opposed to all the way out in year 5 where we have a budget challenge. So that is the sort of process we're going through right now to get us to the point where this budget fits within those guidelines. Now, being the optimist that she always is, Marty reminds me that we have the potential to receive more than the $200 million budget. And of course, we would love to be able to expand those efforts in subsequent years. But our task right now is to submit a budget that stays within that $200 million mark. And so that is the process. And so, as she said, in some of the areas like the funding pools, it may be that we are front loading the funding pools with the idea that as anything above 200 million we may receive could then go back to those funding pools. And so those are the concepts we're working with right now. And so wanted to give you an understanding of the sorts of buckets of the initiatives and where they sit in the budget today. But again, year 2, 3, 4, and 5 require significant work because we've got to get that in place. I thought I had a balanced budget last Thursday, and the HealthWorks folks submitted some wonderful work around workforce, and we're right back to needing to pull some dollars out of the budget and reconfigure elsewhere. So we want to make sure that we have a really balanced approach and are doing our best through that process. If you're an organization that has submitted an initiative that you see highlighted here today and you see an opportunity like that that we may not have thought about, please do reach out to me because this is an iterative process. Any questions on the budget before I talk a bit about food as medicine as one option there? Okay, if not, we'll just jump right in. And how did I bounce back? Accountable food as medicine. So wanted to give you a sense of what we're thinking there. We believe it ties very directly to the MAHA expectations of our federal leadership. In fact, they have flagged these types of programs very directly and very clearly in a host of their work, including more recent federal publications, some recent White House visits, some recent visits with Secretary Kennedy's team, et cetera. We know this is a high priority for them. We also know that food in and of itself cannot be part of the budget. They have made that very clear, even more clear in the most recent FAQs. So we know food itself cannot be, but coordinating, educating, training, infrastructure, all of those pieces around food as medicine can be and would be encouraged to be included in an application like this. And so that is the work that we're exploring. As I shared with you last Thursday when we met virtually, it does incorporate multiple submissions that we received, looking both at the research and agricultural perspective, as well as working and engaging in primary care clinics. One of the methodologies that we are proposing around food as medicine is partnering with community health workers. Now, it was very strongly highlighted in the latest FAQs that community health workers as a reimbursable service represent a very real challenge in this budget. And I want to, again, be very transparent with all of you because they are a billable service. However, we know that when you first start up, hire, recruit, train, onboard, et cetera, those individuals, they are not generating sufficient revenue to support their positions. And given the fact that, you know, as we're talking about deploying 100 community health workers in primary care practices and 100 community health workers in research and education and extension, research and extension is not billed for clinical services in this way. They need NPI numbers and billing structures and all of those pieces in place. So part of the work that we're doing now around accountable food as medicine is trying to project what are those upfront costs in year one that would be appropriate and reasonable and are already built into the budget. But then as we move into years 2, 3, 4, and 5, how much of that community health worker workforce is offset by billable services and how much needs to remain to be funded through this project. And so that's part of the work that we'll be doing this week as we continue to refine the budget. Now, in the estimates that I have seen and the reports I've seen, the level of community health worker reimbursement does not offset its cost at 100%. And so we do anticipate even in year 5, there would be some component of the transformation fund that would continue to provide support to those programs with the goal of working towards a point at which for all of these projects, very clearly stated in the notice of funding opportunity, in all of the FAQs, all of the follow-up we've received, all the calls, all the presentations, sustainability is absolutely key. So we also have to be very careful and balance in this work that what we're proposing has a path towards sustainability. And that will be part of the story that we'll be telling, of course, in the project narrative, but also in the budget narrative. So any questions specific to accountable food as medicine? Yes.
Hi, thank you. So can you give me a little bit of information then about how the food would be covered? Who would be paying for that food?
Initially, the goal would be for those community health workers as they complete their screenings to connect those individuals to existing food resources, dole food boxes, food pantries, vouchers for farmers markets, programs that already exist to provide the support to food. Ultimately, our goal would be to participate in a Centers for Medicare and Medicaid Innovation Award, which would allow for the food. We recently received some questions from CMMI around, okay, how would what does a food prescription look like? These sorts of things. So the good news is they're actively exploring it and asking some good questions. Nothing released at this point in time, but the goal would be to use what food resources we have today with a pathway toward participation in something like that at the national level long term.
Are you also envisioning, I think in the same bucket as extension agents might be nonprofits or community-based organizations?
They certainly could be. We're starting with the research and extension because we need to grow more produce in local areas. A lot of focus nationally and based on data and actually feedback I've received from those who are participating work now. Rural grocers, by the time they receive their produce, it is in really bad shape from everything I am understanding. So a heavy emphasis through research and extension in focusing on engaging with farmers, getting more locally generated produce, more really strong, solid farmers markets available, really that sort of focus. Certainly down the road, once we got that sort of infrastructure in place, and should we receive more than the $200,000, as we're all hoping, that could be incorporated. But right now the focus is on, we've got to work with the primary care practices and identify these folks, get them screened, get them referred, and then we've got to work in the agricultural side to get availability in the rural communities.
Yeah, I was really referring more to the community health worker infrastructure, not the food
right
space.
now, we just have the 100 for each today in the budget. Yes. Yes, that is a key piece of that component from K-State Research and Extension. It includes 4 individuals who would be out actually working in the agricultural community to identify those farmers, to encourage them to share resources and best practices, include some vehicles for transport of that food to get it from the places it's being grown to where it's needed, which is a very real gap right now as they try and match who's growing and who's not. So it does include individuals to do that work. It also includes 29 nutritionists who would work across the community to also work with individuals around those choices. So it does include some of those sorts of resources. Right.
people that
It's
do.
not buying food, but it's creating people to grow healthy food and then looking at the infrastructure we have right now today to cover the cost of the food, which is not exactly what we need. You know, the target, as I've looked at a food as medicine budget that includes food, is as a program like that grows, we need in the ballpark of $3.6 million to pay for food if we want to really get to that point in a food as medicine program. Doesn't give us that. Yes. People online, sorry.
Oh, cool.
What's the difference in the requirements to be a nutritionist versus a dietitian?
You know, that is an excellent point, and I am not the expert in that. So I would have to defer back to the K-State Research and Extension team that proposed them as nutritionists. As we know, there is a shortage of true dietitians in rural areas, and we have to be careful about how thin we spread them. But I can't tell you the exact definition of a nutritionist. Yes.
Field, I'm going to just suggest that there is a significant knowledge gap in primary care in knowing what to prescribe. And so I would not forget educating the health providers as to how to integrate into this system.
The budget does include 8 individuals who would be responsible for that level of practice facilitation. So would be taking evidence-based practice and recommendations and best practice workflows and development of registries and all of that support to a primary care practice to assist them in achieving that, and would have include some of the statewide virtual education and training programs in order to be able to address that specific gap.
There's I don't know what you would call certification called lifestyle medicine that has a lot of the things that we're talking about. So we do have some lifestyle medicine certified family physicians. I'm going to become one of those eventually, I think. But anyway, but that is something to think about as a resource.
Thank you. Actually, David sent me such an email. And so we will definitely look at ways we might be able to incorporate. I was unaware of that certification, so we'll definitely look at ways we could incorporate that into the plan. Back here again.
I was just wondering if your program that you're talking about can collaborate with current programs already available, such as WIC. You talked about nutritionists, and this is where we were talking about the dietitians. Is as a WIC site, we are already struggling to recruit and maintain dietitians, which is a requirement for the WIC programs. And I know that many of us across the state are struggling with this. So I didn't know if there could be a collaborative effort between the initiative you're discussing and current programs already in place, specifically for those nutritionists or dietitians. I know me personally, that my dietitian services several counties. So if I were to lose her, which is a real possibility with the shutdown, if I were to lose her, several of us would be losing a dietitian. A big issue we're seeing is, we contract, so we don't have benefits that are available to them. If we could offer benefits or something along those lines, we might be able to retain them.
We would have to explore that because, as Marty said, anything that's considered clinical service has some very specific limitations, and dietitians would potentially fall into that bucket. So we'd need to explore it. Certainly collaboration, we would absolutely want to collaborate and see where we have those opportunities to engage. And later in the discussion, you'll see, one of the efforts we'd like to explore is integration of public health and primary care so that we can do more of that across the board.
Hi.
Oh, they're telling me we have to sort of move on. So if you've got more questions, please grab me at the break. Thanks.
It's okay. They're adjusting. This is
Oh.
an amazing team.
Okay.
We just keep talking and they keep adjusting.
Right. Okay. So I'll turn it to you on
Okay.
patient
Yeah, we wanted to
facing
spend some
technology.
time on accountable food as medicine plus the community health workers, because that is the most substantial program under Initiative 1. But briefly, patient facing technologies, you appreciate why that's included because of the factor But these are derived from the proposals submitted by organizations. We identified these as very well developed, easily deployable solutions. And then the telehealth rock school-based program, the idea being to bring telehealth into schools in rural areas specifically to address needs at that level. Mobile cancer screening, relatively small budget number, but at least begins building the infrastructure to bring that type of screening into rural communities. And then rural fitness programs, yes, that's trails, but it's a direct improved physical fitness and exercise opportunities. Kansas, as you probably well know, is way behind the nation in those opportunities. So providing funding specifically in those communities that have not been able to meet the matching fund requirements further west to get trails to them. Next step. We have more on this, don't we? We included here the behavioral health initiatives. The number one need regularly cited by rural providers is better support around behavioral health. Specifically here, the integrated behavioral health model to provide those services within a primary care setting, the CCBHC reaching into adult care homes, the emergency department intervention hubs, and then pediatric behavioral health screenings and consultations. You'll see later when we get to transportation, we've also addressed the issue of transportation for behavioral health needs out of emergency departments. We'll come back to that. Then we get to the integrated care for dual eligibles. Those are the two PACE programs referenced previously, expanding into particularly further west, as well as remote ambient monitoring. That's that focus on traditional Medicare beneficiaries not eligible for PACE, but to provide more direct care management services. And then the Sovereign Nation Fund, an opportunity for funding available to the 4 recognized tribes for care in rural communities in particular. Again, rather than, we don't have the time through this planning process to identify needs and specific initiatives, so we created a fund, $2 million available for 2 years. So that we'll work with appropriate representatives to get that funding. Okay, that's initiative 1. Initiative 2. Oh, Q&A. Questions on any of those? What's missing? Yes, Jennifer. Jody?
That is a proposal to place CCBHC case managers in hub emergency rooms across the state, with the concept that they can assist that emergency room staff in doing the initial assessment and identification of next round of services, could engage a telehealth consult where appropriate, could also engage for surrounding communities that don't have an embedded CCBHC case manager to be able to connect virtually to assist in that same sort of a way. Does that make sense?
Yeah, so the other is with these patients that get placed and they're sitting in the ED and waiting so they can get the crisis assessment, but we're waiting on a bed, right? So the problem is they're also not getting any pharmacologic therapy. So the proposal is that while we have the case manager there and they can do the initial assessment, decide the placements needed, then a telepsych consult could be arranged to start on pharmacologic therapy. Our theory is that these patients would then have most likely a shorter stay in that state bed by getting started on therapy, and hopefully also be a little bit better able to be managed in a setting where they're not always surrounded by folks that are comfortable with managing those patients.
Just a quick question on the pediatric behavioral health screenings and consultations. I understand we can only fit so much in a bullet, but is consultation sort of broadly, would that include interventions, like evidence-based interventions?
Dr. Miller said yes for those who cannot hear. Okay, initiative 2 is securing local access to primary care. Again, the objective here is improving, reducing the number of hospitals with negative margins. Again, it's an easily measurable objective indication of the availability of primary care services in local communities. There are 5 programs here, starting with right-sizing primary care delivery, which is the model for integrating public health and primary care to better leverage those resources in local communities. There's an emphasis in the NOFO on right-sizing care. So we wanted to identify what's ways we can bring services that seem disjointed in a local community together. Secondly is the Regional Strategic Partnership Fund, dollars available. Jody, what's the amounts in years 1 and 2? Sorry, I wish I. But this is a big chunk of money available for these initiatives to build these rural, regional, both clinical and operational structures. There's the REH Conversion and Transformative Capital Investment Fund. So this would be dollars available to hospitals considering the transition to REH, particularly focused on needs to revamp their facilities to meet the requirements for REH status, as well as transformative capital investments made for any rural facility that can clearly link the capital need with transforming care delivery in their community. So if you want to buy an MRI and you want to apply to this fund, you better be able to tell us exactly how the availability of that service is going to be transformative to your community. Number 4 are revenue improvement tactics. There are 3 projects specifically listed here, doing a statewide commercial rate analysis. It's work done by the Kansas Hospital Association last year has identified one driver of poor financial performance for rural providers is low commercial payment rates. We can look at the available transparency data. It shows that Kansas rates are significantly below other comparable states. So this is an analysis to truly do a statewide view of how our commercial payer rates compare to Medicare rates for different types of providers. Revenue cycle support and credentialing organization, again, centralized services to support multiple rural providers, and direct to employer Heartland Partnership that is exploring direct to employer relationships between provider networks and large employers in their communities. Number 5 here is the Anchor Hospital Advancement Program. When we call the term Anchor Hospital, you may sometimes hear the term Regional Referral Center, but we wanted to avoid that terminology because it has a special meaning in the Medicare reimbursement world. But this is how do we ensure that those hospitals to which our critical access hospitals refer patients for specialist services, how do we reinforce and secure those hospitals, both financially as well as their ability to deliver services and coordinate within their network. And that would be the Anchor Hospital Advancement Program. 3 projects under here, including the Vizient Clinical and Operational Improvement Analytics. So appreciating for these anchor hospitals, how they compare and where their opportunities are for performance improvement. Managed care advisory resources, so contracting issues and other support around managed care. And then on-demand operational resources, for example, how do we provide cybersecurity support to those anchor hospitals as well? So that is initiative 2. Questions before Sheena tells us about backups? Yes.
Thanks. Just a quick question. So I know the objective is related to the negative operating margins for rural hospitals, but I'm wondering when you look at the statewide commercial rate analysis and going back to the initiative being focused on primary care, will you be looking at rates for other kinds of primary care providers other than hospitals?
Yes, absolutely. The trick there, I'm going to say this now, and I'll say it again for the next 5 years. It will be the cooperation of those providers furnishing the data requested for the analysis. It is, and I am the first to say that is a time-consuming process. There are dollars that'll be tagged towards helping that data collection, but that is going to be a critical component. This isn't something that could be done in the background. It requires engagement by the providers to provide the data that can then be analyzed and compared appropriately. But again, part of that reason for tagging this as a project is to get the monies to support the providers in compiling that data and then separately having it analyzed. Sir?
Each supporting hospital now, or are we talking about other rural hospitals could be considered an anchor hospital.
Yes, others could be considered anchored hospitals. So be analysis, but again, it's a moving definition, right? If we had a 6-month planning period, we would have consensus around the definition. But it's looking in the regions of the state to whom are primary care providers sending for specialty services. And so in some instances, that's going to be a critical access hospital. In other instances, most are going to be PPS hospitals.
Okay, and anchor hospitals could be obviously in rural or
Yes.
urban
Yeah,
areas.
they're all rural. They're all rural. Except yes, absolutely. The anchor hospitals are all in rural counties. It is not the Via Christi's in Wichita or the any other of the urban hospitals. Yeah, this is very clear on that point. Thank you, Chad. That is rural anchor hospitals. Yep.
Obstetrics in rural areas have become an issue for our primary care providers because the hospitals, critical access hospitals, say they're losing money because of the way cost reimbursement is done. So I don't know if this could be part of the process, because for us personally, we've lost Scott City, we lost Norton, I'm in Quinter. We went from delivering 60 babies a year now this year, maybe up to 150 because of the loss of people around us delivering babies. And so this is part of the reason obstetric deserts are happening, because of the lack of funding and the reimbursement stuff. So I don't know if that fits into this or the next initiatives.
That fits here. That is our regional strategic partnership fund, would be dollars available as you explore opportunities for leveraging services, explore alternative payment models that may work better than the lower reimbursement we have today. So that is our Think Fund, our Dream Fund, and really prioritizing those initiatives, right? Because the need for better maternity care is going to compete against, not compete, but there are going to be other priorities. And the idea of the fund then is we can look at that from a broader perspective and allocate the dollars that way.
I think also, as David and I had talked about on his podcast, I made my county a maternity desert, and it broke my heart after 15 years of delivering, because I became the only delivering provider for the last year. And obviously that's not sustainable. And we worked really hard to try to recruit. I don't know what else I possibly could have done, but we didn't find anybody else. And one of the things I would say that, while sad in a way, our CFO was probably not that sad when it went down, because they always told me, we lose money on you doing this. We lose money on you doing this. And so when I also brought up the prospect of getting it back, if we get more people, they were like, oh, that's never going to happen. Like, that will literally never happen. We would never be able to get the funds to restart this. So that's another, I think, fear, right? Is that even if we get the providers and we do that, the pushback from facilities saying, not going to do it. So there may need to be, if we are able to grow these things, also some help and thought of how do we help these hospitals like overcome that to get back a maternity unit.
Right. And that's the exploration of, are there a 5-county region that can look at identifying one hospital that would provide the OB services, but be supported by the other communities as part of that. That's that creativity within that regional strategic fund. There's also, and I should have previewed this, when we get to workforce, rural residency programs include OB.
Is there, is there a vision to connect this to the Transforming Maternal Health Grant that KDHE got last year? So it's a 10-year, $17 million grant to sort of explore different alternative payment models in alternative workforce, which I think probably aligns pretty well with the overall goals that you've all laid out.
That is true. We do have to be very careful. They're very clear in the NOFO as well that we cannot duplicate, replicate, or pull away from other federal funding sources. So as we've received initiatives, we have had to circle back and say, okay, I know this at one point this was HRSA funded, or et cetera, and where is there any overlap, et cetera. So we will need to be very careful about that. Yes, we must do that duplication analysis. So we're seeking all of that So coordinating, collaborating, absolutely, but very specific guardrails.
And when we talk about the value-based care initiative, the Medicaid alternative payment models, again, large percentage of those moms are on Medicaid. Are there opportunities for exploring that to make it more, a less financial drain, shall we say, on facilities?
I have one comment again about the statewide commercial rate analysis. Just be careful with that, the perception of that, because we know we've worked a lot on this as to what power do we have to make a change anyway with those contracts these days. So is an analysis really going to serve the purpose of making a difference with RHTP funds? I wonder, we've started the initiative of a payer scorecard, which is looking at that and that more along the lines of analysis on denials and prompt payness of payers, and maybe utilizing the funds for more of an expansion on that versus making sure. I just want to make sure that we're making a difference with the funds versus just analyzing and what's gonna come from it.
Can I take that one, Marty?
You got it.
Okay. So the way that analysis makes a difference is it gives us the information we need to come together and negotiate. Because individually, you are absolutely right. If we only have an analysis and we know, and I can tell you 10 years ago, George Pink at the Rural Health Center stood up at an NRHA meeting and said, in Kansas, their #1 issue is poor commercial payment rates. And that hasn't changed in the last 10 years. We have to have the information in order to have the leverage in order to come together and negotiate as a group. Now, we had a lot of submissions that talked about the formation of rural clinically integrated networks. And if we funded all of those in total, there would be no budget left for anything else. But this at least gives organizations the baseline information they need in order to actively and appropriately participate in that kind of work. So it's really a foundational investment
for other
for
projects.
other, yeah, it's not a strategy in and of itself, but it gives us a foundation along that line. And Marty, you had asked about the dollar figure, and I have worked these budgets so hard I wanted to confirm I was right. 24 million a year. It is the #1, these sorts of strategic partnerships, innovative opportunities, #1 set of submissions of the more than 200 we received. And so we put a significant dollar figure in year 1 and 2 for that particular fund, and would certainly hope to be able to continue to expand that should we receive additional dollars. But 24 million is where we sit today.
Can I ask a quick question about a couple, one from the previous initiative and this one, for right sizing primary care delivery and for the integrated primary and behavioral healthcare one? Since we're not paying for, or since the fund is not paying for the direct services, how are those funds being envisioned being spent? What's the budget?
I'll flip you for it. Well, again, it's the technical assistance to assist these practices in changing their operations. And so if I'm going to say, well, I want warm handoffs to behavioral health in my clinic, how do I work with the providers so that they can adopt appropriate practices, they have the right staff, they do the training. But then if you have staff providing those services, that's then a reimbursable service for integrated behavioral health. For public health, it's the same issue because yes, services are paid for through the health department, services are paid by primary care. The issue is how do we prevent the duplication and how do we merge the two as appropriate? So we don't need to have, in a small community, do we really need immunizations being tracked by 2 different organizations? Can we consolidate that? Can we bring annual wellness visits on a community-wide basis under one roof as well? Jody, anything to add?
Just that in the research that's been done around integrating public health and primary care, as Marty said, they recommend starting with those things where that are activity-based, immunizations being that sort of an example. The various activities where both of us do that together, we could potentially expand access rather than duplicating service, which is a good place to start. It then proceeds down, as you might imagine, a trajectory towards, okay, beyond that, what sort of contractual arrangements might we have with one another that would help us better meet the social determinants of health in our community, et cetera. Could lead all the way theoretically to merger, although that rarely happens, could lead all the way there. But it really is sort of a facilitated process to say, okay, where are we sitting now? Where can we expand access to our community if we coordinate better? Where can we use our funds more efficiently and effectively if we coordinated better? And then what more might we do together? Yes, yeah.
You ready? We're good. We're done. More questions? She's gonna let us go to breakout if you don't have more questions. Okay.
All right, so we're gonna switch up the plan just a little bit. Lots of good discussion, so we don't want to cut into the discussion time with the group. So at your tables, I referenced that you have the note taker. So what we'll ask you to do is at your tables, facilitators will be walking around and assisting with discussions, but you'll have about 10 minutes to go ahead and under initiatives 1 and 2, start to discuss and answer the questions at your table. And then we'll have a few minutes to share key takeaways. So you can begin. Okay, I'm going to bring us back together. So please wrap up your discussions. All right. Thank you everyone for such engaging discussion. I know there were a lot of good questions and answers that were provided. Thanks to the team and the facilitators for walking around and assisting. All right, so this is what we're going to do. Each table I'm going to ask just to share some key takeaways. We're first going to discuss initiative 1. Wyatt is going to be back there recording what we share out for us. And this is the only exercise that's separating you from lunch. So we will move along. All right, so I will go ahead and turn it over to this table first. So for initiative 1, what elements of the proposed project stood out to you as the most important for rural health in Kansas in initiative 1? And what did you identify that might be missing from the plan?
So for number 1, I think we kind of focused on the talent recruitment and retention having the most potential, as well as kind of focusing on the ACO model for primary care quality improvement. And then questions that we had is, how do we prevent a siloed approach to care? Like, for example, there's mentioning that there's not a medical home component for care coordination. Then in terms of strengthening, we felt like the food as medicine funding should, I know that there's limitations to that, but include that nonprofit coordination component beyond just the extension program.
I think one other piece that we talked about was just really digging into the pediatric behavioral health. So thinking about what those evidence-based interventions look like. And then we really got into maybe helping build the infrastructure at CCBHCs to help serve those infant and early childhood populations, which they're mandated to do, but there's some real gaps there. So there's some recommendations I think that KHI had pulled together last year that might be helpful to look at.
Thank you. All right, moving on to this table over here.
We didn't really do question 1. We were asking lots of questions. So thank you to Jody and facilitators for help answer them as well. But I would say a theme that emerged for strengthening, and not to say it's not already part of the plan, but I think it was really clearly stated here, ensuring that we're clearly stating the benefit to the rural communities when there's something that could be like a hub and spoke model, really leaning in heavily into the benefit to the spoke. So I think that was true for both initiative 1 and 2, but particularly we heard that in initiative 1. Also a reiteration of the need, if you're going to have programs that require providers to do something or expand the providers doing that thing, that there's education included and as a component of the proposal and the implementation plan. Anything else, team? All right. Thanks.
Thank you. All right, over to this table. What were your observations about Initiative 1? What did you discuss at your table?
I'll mention one of them that we talked about. Several good things. I think one thing that came to our mind, we felt the behavioral health and the accountable food as medicine felt like the ones that have most power for transformation. The others all seem strong as well, but those emerged, at least in my notes, as ones that we thought were most powerful. One thing that we did talk about is trying to get our arms around, out of this list, which ones are these really about primary prevention? And how do we get really clear and strong with the narrative about that? Because a lot of them seem like they're about secondary prevention, which is also fine, but are the primary prevention pieces strong and clear enough? And how do we make that as clear as possible, given the emphasis on MAHA at the federal level?
The other thing that I think is missing from the patient-facing technologies is the opportunity for remote cardiac rehab as a Category A recommendation. We try to encourage that, but the incidence of completion is super, super low in rural Kansas. So if we could get that on a telehealth type basis, I don't know which the best platform it is, but it's something to think about and something that should make the list.
Thank you so much. All right, over to this table. Could you summarize your discussion for us?
Greg wins because the microphone's closer to me. We discussed, I think the three areas that percolated up for us were accountable food as medicine, behavioral health integration, and then trails. I think on the food as medicine piece, it was just clarifying, I think, and figuring out exactly how that would be operationalized across clinics and regions. Also, making sure that we were looking at some low-hanging fruit, like thinking about food insecurity screening into the state's tobacco quit line as a way to cast a wider net. It's a pretty easy win that other states have considered. Also, looking at specific metrics for food as medicine and potentially drilling down a little bit deeper to get more specificity around things like wound care, limb amputation, kidney disease treatment, those types of things that might be more readily available on a quicker pace than some of the higher level chronic disease metrics tend to be. On integration, we made the note of making sure that we're considerate of integration on both ways, behavioral health into primary care into behavioral health, especially for areas that have limited primary care access or hospital access, and mental health becomes an anchor point in those areas, and how are we filling those needs. Also thinking about integration as a way of getting further up the pipeline and into that primary care space, and using integration to identify patients sooner in their mental health journey. And so getting them identified and into treatment sooner before they become further down the pipeline in cost and in diminishing quality of life. Trails, we made the note that any community you go into that has a robust trail system, you can immediately notice a difference of people outside and people connecting to those, not only for health, but also for economic vitality and other components that are important to community. So pretty limited, a pretty low cost intervention for the type of impact that you get. Greg, did I miss anything?
All right, anything missing that you identified?
I think it was probably not so much that we thought it was missing, but it's just, when you're looking at a limited outline, these things are probably there. It's just that as we're looking at that. So it was things on like digging deeper around what are the metrics on some of these things, exactly how does cost end up flowing out across the system from a budget perspective, who's in and who's out in terms of who can access those dollars. So not so much that it's not here, but probably it's in the details that are being worked out right now, I'm guessing.
Thanks, great feedback. All right, I'll move over to this table. Can you summarize your discussion about what you felt was most transformative, anything missing, other discussions?
Well, I mean, our projects that we felt have potential really focused around community health workers more, and I know that hasn't been talked about as much, but I know, especially in our hospitals and rural health clinics, although it's funded, it's barely funded, and so it's not sustainable cost wise currently with community health workers. So, and that burden was on our hospitals and rural health clinics to try to, again, connect people with the services they need. But they just don't have the experts in our rural hospitals and clinics to do that. So if that can be an added process, we see that as beneficial. We focus the rest of the conversation more on concerns, and the first one was around food as medicine. And I guess I kind of dominated this conversation with a story that I told that I started community garden in Kingman. It was great the first 2 years. We connected with the community, we got the food out there, but if you don't change behaviors, people aren't going to use it. Half the food after year 3 sat there and rotted because the community, it was easier to fix ramen noodles than to take those vegetables and make something out of them. So you're missing step 2, which is how do we change behaviors versus just adding more components of the food that's out there. The second concern was I'm sitting with the community behavioral health people, is are we doing an unintended consequence by putting more people in EDs and long-term care, such as therapists and those behavioral health specialists, and an unintended consequence is hurting their workforce in their community mental health centers, because they struggle now with that workforce, and is this going to make it even worse? Did I miss anything in the 2 things we talked? Yeah.
Thank you for sharing. All right, over to this table.
So we echo a lot of what has already been said. As the pediatric and geriatric table here, we talked a lot about primary care and keeping the focus on primary care, like you guys talked about over there. And the 2 main areas we looked at were accountable food is medicine, and then the behavioral health aspect, especially the pediatric behavioral health aspect. We feel pretty strongly about that. I think when we were talking about things, a lot of what we discussed was, and again, it's a shortened time frame, so we don't really know a lot of the fleshing out of all of these things, but are there opportunities in here to partner with other programs like we talked about with WIC earlier, SNAP, those kinds of things with the food as medicine? And then there's other opportunities to help with education for providers in terms of those kinds of things as well. We talked about patient-facing technologies, how that would be really helpful for rural patients and providers, and how education needs to be in play there for the folks doing, actually hands-on doing all of that, because that can be a little bit tricky as well.
Thank you so much. All right, this table over here, what felt most transformative to you out of the initiatives you discussed?
All right. Integrated behavioral health, I think, was number 1 for us. And one of the points we wanted to make is that work's been going on for a long time in parts of Kansas, and we probably should study the bright spots, see if we can make that make more sense for other folks. We also talked about food as medicine, the opportunity to engage large employers in projects like that. We're currently working with B&W Hitch in Humboldt, and it's been a really successful project so far. So think about private employers. I think the ED intervention hubs is a really important idea and really timely. And I think there's a lot of people that touches a lot of systems. It touches transportation, it touches mental health. But I think we want to make sure that there are lots of opportunity for all kinds of providers to participate in that, and not one kind of provider. And then PACE. We talked a little bit about PACE and the opportunity there, but my own ignorance, I don't know what some of the administrative restrictions are on how we can provide PACE in rural areas, especially over a big service area. Because when we pursued that, there weren't enough bodies for it to make sense. And that seems like not a good enough answer. So if there's some state level intervention or policy we could do on PACE, we thought that was a good opportunity as well.
Thank you very much. And last but not least.
Yes. So to not duplicate too much of what has been said, the two main items that came to the top of our table were also the behavioral health focus and food as medicine. Maybe really the main suggestion items related to the food as medicine piece, putting a fine point with that question of nutritionists. Where is that piece of the workforce coming from? Maybe it's spelled out in the plan, but a lot of potential concerns and unintended consequences of if dietitians in many rural communities already are in more of a regional collaborative format, how are we going to ensure that they don't leave where they're already at to gain benefits somewhere else? Are there ways we can look at addressing that more proactively? Don't want to exacerbate that side of the workforce. And additionally, with that food purchasing or sourcing, if one community already has 100 referrals to maybe their local food pantry, if these efforts are successful, which hopefully they are, if that community now has 200, how do we just ensure that supply and demand piece is actually able to line up? But any other key points from? Okay.
Thanks, Jaron. All right. So for initiative 2, I think we'll just take volunteers. So any tables want to share about transformative areas that they felt had the most potential in initiative 2?
So we had a good discussion about the credentialing process. It doesn't describe it as well on here until I heard how Shannon described it. But the idea of centralized credentialing through a central place instead of all the individual carriers, all the individual locations, what an impact that could make. And I would hope we'd include behavioral health as well, but have a statewide concept of somebody is already credentialed and then the carriers and everybody is just required to pay because they're already through that process. I think that would have an enormous impact.
Thank you for sharing. Any other thoughts on priorities for initiative 2? Oh, sorry.
I just think when we talk about the regional fund, I think that's really important that it look across both provider types, right? So that somehow, how do we give an incentive to bring your CCBHC, your FQHC, your rural health clinic, your hospital? Like, we have to cross systems, and that's a problem of policy as well and how we get paid. And I think you can only cross that by getting some funds in it that really promote the idea that these projects have to cross those systems.
Thank you. Anyone want to share about anything related to initiative 2?
I guess just one more comment about the right sizing of primary care. I think it needs to be very clear that the right sizing is more. We need more, and if you're looking to try to squeeze out extra funds by integrating public health and primary care, there's not a lot of waste there. That's my sense. We need to look for the dollars elsewhere.
Maybe votes for a name change. We don't know. All right, thank you. Anything?
I think it's an excellent point, and we weren't looking at it in terms of squeezing dollars out. We were looking at it in terms of if we worked together, how could we expand what we're able to accomplish together? As opposed to the more common definition of right sizing that, quite frankly, we're trying to do all we can to avoid.
We echoed that concern and just making sure that in trying to be efficient, we don't actually further fracture care and find ourselves pushing people out of those rural areas for the care that they need in the follow-up. So that integration is important. And then of course, drawing them in. So something we thought about too.
Thank you. All right. Any other considerations around initiative 2? Good. Okay. Well, you do have an opportunity to continue to think through initiatives 1 and 2 and take notes on your discussion guide. As a reminder, we'll turn those in at the end of the meeting so that the application team can incorporate any feedback. Now I will let everyone go ahead and transition to lunch. It's outside in our galley, so please go and take care of your needs, get lunch. We'll have about 20 minutes, but we're going to treat this as a working lunch. We're going to roll right through. So please take a break, get some food, and we will come back and resume at about 12:20. All right, everyone. I'm going to invite Jennifer Finley and Jaron Caffrey with HealthWorks to share and explain Initiative 3. We will go through Initiatives 3 through 5, have some time for questions, and we'll repeat the same process that we did before for our exercise and activity. So welcome, Jennifer and Jaron. Jaron's going to start off.
All right. Well, good morning, and we'll try to keep things moving on these. We know there's a lot of detail over here. What you see for Initiative 3 under Workforce is really geared towards 4 different programs and a variety of projects underneath all of those 4 programs. And so to start things off from left to right with a physician pipeline, we've identified 3 main projects under that program area. Number 1 being an expansion of rural residency programs. So we want to train more physician residents within the state of Kansas. There's a lot of research and evidence out there that shows where a physician resident trains, including as a state, and especially in a rural area, they're much more likely to then eventually practice and retain in that area. And so we'd be looking at that, particularly with a focus on, of course, primary care and psychiatric specialties, but also potentially looking at general surgery, orthopedics, and OBGYNs. Secondly, an expansion of the Kansas Bridging Plan. So this is a program that is already in existence. However, there are some limits. It currently has a pretty narrow limit on the number of money that it can support, the number of slots that it can support, and the specialties it can support. This has an over 85% effectiveness rate in terms of bringing, after physician residents complete their residency, bringing them into rural Kansas and actually retaining them in rural Kansas. And so this would look on expanding upon that, again, in terms of the number of specialties, the number of slots, but also that dollar amount to really make that program potentially even more effective, and potentially is having a lot of more short-term effects on getting providers into rural parts of the state. And then the third project under this program is some funding for medical students to be able to provide and access housing for a rural rotation. We know that there are many sites, whether it's a hospital, clinic, what have you, that would want to provide rural rotations for medical students, but often a limitation is that they do not have accessible housing that meets some of ACGME or just regular ACGME standards or just regular housing availability. This would help provide a stipend for getting an Airbnb, a hotel, whatever the case may be, to actually provide those opportunities. The second bucket here, education and training. A lot of items under this. As you heard earlier, we pivoted from Friday with some of the FAQs coming out that loan forgiveness and loan repayment cannot be an eligible opportunity under this. So refocusing that a little bit based on what was read, I feel like scholarships still can go under this. And I think the table up front agrees, at least as of today. So this would create a health professions service scholarship program. This really being a large bucket modeled somewhat after the nursing service scholarship program that is already in existence. There really is nothing, though, for the allied health and other professions. And so this casts a very wide net, and truly meaning whether that's community health workers, whether that's EMS, whether that's our behavioral health pieces of the workforce, and of course, things like radiology, lab, et cetera, some of the therapies, including at the postgraduate level, that rural parts of the state have key vacancies in. This would really help provide scholarships to incentivize folks to pursue those programs, and then have that tied 5 years of service in a rural part of the state, and as a condition of that. Very similarly, there'll be a dental scholarship program to address that piece of the workforce. Next, mobile simulation labs and programming. So of course, it is very hard in many parts of the rural parts of our state for professionals to keep up on certain skills that maybe they don't always see high volumes in. This would help mitigate that and provide actually simulation labs to come to our rural areas to deliver those skills trainings and what have you under that related bucket. And then lastly, another fund that would be created, a healthcare training fund that would really try to capture several pieces that I believe last Thursday when we had met, we highlighted more projects under this umbrella. We're folding putting a lot of those under this fund, under education and training. So this would include money to help support whether it's practice and academia to create more degree or certification training programs, whether that's for community health workers, EMS, community paramedicine. Some parts of our state might not have surgical tech programs. That would help provide and bridge those gaps. So we mentioned then community paramedicine training, CHW training, but also the CHW training and certification hub to fill the gap of, in the last couple of years, some of the transitions without really having a body in the state to recognize and license and have some of the oversight with community health workers. This will help with a variety of those pieces and potentially more yet to be defined. So that was a lot under those two buckets, but I'll pass it over to Jennifer to cover the others.
And I think under the training fund, we're trying to keep it generic. So as needs develop, as other projects start to mature and we see there's a training component needed, we have some funds set aside to help provide that skills development. Third bucket is under recruitment and retention. And a wide variety of activities here. The first one is let's try to get more people interested in rural Kansas. So a good old-fashioned marketing campaign. Why is it exciting to work in rural healthcare and especially in Kansas? And secondly, did you know we have a lot of jobs in rural Kansas that you might not have been aware of? So let's try to generate some more interest there. Creating a rural nurse residency program to really help sustain nurses once they graduate and get into their practice to provide the supports they need to continue to be successful. We see a high rate of turnover once they graduate, get into a facility and feel overwhelmed. This is an evidence-based program that helps shore up some of those gaps. Making available more clinical sites. We hear this from a number of different programs that they need more places to train. And one of the big reasons that they can't expand that is they don't have enough bodies within the facility to act as the instructor. So some stipends to incentivize organizations to actually have employees be clinical instructors, but they'd be embedded in the organization, not part of the academic institution. And then they also can serve as preceptors as folks are going through school and then again coming and entering the workforce. Developing a behavioral health apprenticeship program. We have some great success already in the state with healthcare apprenticeship programs, but we need some additional work in the behavioral health side to develop some real curriculum and structure there. So we want to put some dollars towards that. And then really making sure we're taking care of the folks that we already have working in healthcare. We already know the significant toll that COVID and other things have taken on our healthcare workers. So focusing on them specifically with a number of wellness initiatives. Across the spectrum for all healthcare employees, these services would be available. We have a lot of experience working with some evidence-based tools that really have shown significant improvement in overall well-being, as well as then side effects like reducing patient errors and some of the other things. So we think that there's some great causal links we can draw there. And then an annual wellness summit where we really will focus on employees as a whole, talking about healthy minds, healthy bodies, financial health, all of the aspects that go into making a healthy employee. And then the fourth bucket, really around incentivizing folks to consider healthcare careers. So let's go back to the very beginning. Let's start talking to kids about why a healthcare career might be exciting. So looking at expanding and building more on the HOSA Future Health Professionals program in our state. If you're not familiar with HOSA, it's a student-based organization that's focused on health careers. So we want to expand some of the curriculum to include other health careers they might not focus on now, getting more chapters in more high schools, and then supporting their overall structure to have more experiences and events that kids can participate in. Expanding CETE programs in Kansas, specifically around healthcare careers, looking at our K-12 institutions. Some have programs, some don't. What are the barriers? What are things that we can do to help expand those programs in all high schools, especially in the rural parts of the state that don't have them right now? And do we need to add some additional programs? Looking at high school certification and pre-apprenticeship programs, we've been very successful in some areas of the state in training high school students and certifying them as CNAs. Can we take that model and apply it to other low-level entry type positions within healthcare, setting up the infrastructure to create that process? And then looking at regional career expos. This would be hands-on experiences for students out on a regional basis where they can come together, learn more about careers, but actually experience what it might be like to work in a healthcare field. Some great models out there already, but we want to expand those statewide. Are there questions?
A quick reminder, we are live streaming this meeting for members of the public. It's available on KDHE's website, so that's one reason why we'll ask you and remind you to use the microphones. In addition to, we do have a couple of participants joining us via Zoom due to their ability not to be able to travel. They're actually providing care in rural areas of the state. So thank you for your understanding. And now, yes, we'll turn it over to questions.
So I don't know exactly, I guess under education and training, could this consider, there's been discussion, for instance, at KU about recruiting high school students and creating an early admissions program for like a high school student directly into the medical school so that they then go on and practice in Kansas. Is that the sort of scholarship and education that could be considered to fund that sort of a program that's, involving high school students from the outset and creating a shorter program to get them trained and into practice in Kansas?
I think those are exciting models to look at. We try to, under the guidance of folks who are more familiar with academia, stay away from things that would force changes in the overall academic structure, knowing that we have to deliver things very quickly. But I'm hoping that through the training fund, those are some things that we could study and bring out models to support.
So if that was already underway and they were already working to do that, then they wouldn't be eligible for the scholarship because it's already being developed.
Well, the scholarship fund that's here is specifically towards allied health professions because there isn't an existing scholarship program for them.
Okay.
So like they would still be eligible for the medical student loan program and some of those other SLRP, the state loan repayment program on the back end. But right, to Jennifer's point, that when we're talking scholarships, we're not talking medical students because we're trying to find some of the other gaps aside from the stipend, of course, for medical student rotations.
There's a tremendous shortage of EMTs in rural Kansas, I'm sure you know. So that's a huge emphasis that ought to be addressed with this. But also, you mentioned the CNA certification through high school. I wondered if EMTs have ever been studied in that along those lines too.
We're looking into it.
Okay.
But yes, that's the same idea, looking at other professions beyond CNAs that we could expand. And that health professional service scholarship would also be available to EMTs.
Just a couple of comments. I think I just want to make sure that when we're talking about the statewide wellness summit, that we're making that a unique, just from my own experience, it's unique. It's not just lecture and a conference center. And then it's not just directed towards employed for providers. It would be for independent providers.
Anybody that works in healthcare.
And then the same with the clinical instructor and preceptor incentive programs, ensuring that that's not just set for hospital or employed physicians for the preceptor incentive programs. Just the majority of our members are not employed. And so and a lot of them do precepting for family medicine, obviously. So we just want to ensure that they were included in that
I think
piece.
we're going to try to write as many of these as generic and broad as we can to apply to different environments.
Okay. And then my last comment on the regional career expos. I don't know if you're familiar with KU School of Medicine in Wichita and Kansas City both have the Kansas Career Opportunities Program. So it may just be an opportunity to integrate them as well.
The clinical instructor and preceptor incentive program, where is the funding coming through and where will the funding come from in 5 years when the rural health transformation funding is over? Because I'll tell you, if you start paying people for 5 years and then you take it away, we will actually do the reverse and we'll have fewer preceptors.
I think initially we were looking at this as a hospital-based model. Doesn't mean it can't grow, but that's where we were initially looking. And we know from experience, if hospitals are providing activities that are generating more employees for them, they become sustained because it's a pipeline for them to continue to get workers in the door. So we're hoping part of this is evidence-based for the hospital to want to continue to provide that, but the funds would be coming to the institution, not to the individual. Anytime we give funds to an individual, we have to ask for a 5-year commitment. So we're trying to be really careful about how we structure things.
And I might just add, I know we can't always bank on the legislature to provide something for the sustainability piece, but this is a somewhat similar model that had been introduced in legislation and had a hearing on. And so I think that there's a idea that maybe this could grow legs, throughout the next 5 years as a potential another funding source.
Any other questions? All right, we will transition and discuss initiative 4. Enable value-based care.
As you'll recall, the objective associated with this initiative is to have all rural Kansas Medicare and Medicaid beneficiaries in an accountable care arrangement by 2031, consistent with CMS's objective for traditional Medicare and Medicare Advantage. And this is truly, I think, of all the initiatives, the one that pulls down funds as investment opportunities to build infrastructure that is desperately needed for the transition to value-based care, but where the resources have not been available in a fee-for-service system. So it's a disruptive, innovative dollars coming into the system. That starts with managing total cost of care. There are many providers who have not had the opportunity to work with data to understand what drives total cost of care for beneficiaries. They have not had the opportunity to build the infrastructure that helps identify individuals for appropriate risk scoring. They have not had an opportunity to fully develop out preventative care programs that are also contributing to appropriate management of total cost of care. So these initiatives, as developed within this overall program, are reflective of what national ACO management companies have been doing. We're just going to bring that to local Kansas rural providers. Number 2, evidence-based practice incentives. One of the second, is this the second largest pile of money, Jody? It is. This is creating the incentives for all providers in Kansas, physicians, hospitals, CCBHCs, FQHCs, to have a set of clinical standards tied to specific performance metrics and report on that data. Well, first of all, of course, have I don't want to say technical assistance, quality improvement in performance support for these organizations as they implement those evidence-based practices, as they develop processes for gathering data. But the submission of that data, scoring a performance on that data, having that tied to payments directly to the practices. Advantage here, separate and apart from obviously the development of that critical skill set of evidence-based practice and reporting of data, but it's just a way to get dollars immediately to these practices. Of course, when the fund was first announced, when the program was first announced, everyone thought they're going to get a check in the mail, right? And we had to kind of dissuade rural providers of that notion. But this is a way we can have a very broad-based, immediate impact, getting dollars to providers across the board. The transportation program, you're saying, why is transportation in the value-based care program? Well, if you're going to build an effective care continuum where a patient goes from a local community to a higher level of care, you have to have adequate transport in place to accomplish that. So here the elements include a new, Jody, you have to describe this one, Dr. Mosher, the Global Response 911 React. So I'm going to do it justice.
I know I love it.
So some of you may remember during COVID, there was a program that we had actually been using within our um, rural accountable care organization as a way to address the hospital transfers, bed availability, et cetera, at that time called Mission Control. And that program does not currently exist, but we're getting a lot of requests for something along that line that supports hospital to hospital transport. But beyond that, we also know that there are these issues within a rural community, and the research suggests somewhere in the neighborhood of 16% of patients, when there's a 911 call, it's not really an emergency, that it is something that could be taken care of at the patient's home, or could be transported instead of to a hospital emergency room, to a clinic, to a CCBHC, some other venue of appropriate support, or let us help you get an appointment because it's not urgent that you're in crisis today. Let's get you an appointment for something down the road. And so 911 React is designed to support those dispatchers that pick up the 911 calls with a team of nurses who assist in that triaging of the patient to determine what is the actual need of that patient, and helping guide local EMS and local resources. So in an individual community that may be very, very short on EMS support, but may have some other resources that they could bring to bear, they have the flexibility then to say, okay, 911 React has suggested this is not necessarily an emergency. What other options do we have in our rural community to support the needs of that patient? And then, as I said, they would also incorporate the hospital transport, which is a tremendous need across the communities. Similarly, behavioral health crisis transport has come up in many, many, many of the stakeholder discussions. And so it also includes a specific set of dollars around providing behavioral health transport, which does also include OUD, SUD assessment support as well. And then we're incorporating the EMS transport in place, or transport to an alternative place model. It's really a component of what you think of as mobile integrated care. But it's a major step forward in being able to say, right now, as an EMS, I arrive at the patient's home. This is not an emergency, but if I don't transport them to the emergency room, there is no reimbursement whatsoever for the cost of that call. And so some commercial insurance does cover this, but Medicare and Medicaid today do not. And we know it is a significant portion, as said, roughly nationally, about 16% of patients who initiate a 911 call fall into this bucket. Yeah.
So would that treat in place maintain the current protocols that are required for EMS, or does it go past those? Does it allow for further treatment than would be allowed by protocols in place in Kansas?
They would need to have clearly defined protocols. Yes, absolutely. And the potential for ability to connect for a telehealth visit if the local primary care practice has that availability and that infrastructure, which would be part of what we'd want to develop, because we don't want to further fragment care.
So if they didn't have that telehealth capability, then they couldn't treat in place?
Well, instead they would transport to an alternative location, so they could transport to the primary care practice.
So they wouldn't be independently treating in place? I mean, they would have to still work within physician direction?
Yes, yes.
Okay.
Yeah, they would have to work under clearly defined local protocols, yes. But it does then allow for a level of reimbursement that supports that within the local framework. There are some programs that do, telehealth with someone on the other side of the country. And we felt very strongly that we did not want to fragment care. And so the goal was to really say, what resources do we as a community have such that we could be able to support this kind of care locally, if that makes sense. Dr. Mosier?
Yeah, just one more thing to add that needs to be part of this is public education. In looking at our data over the last 11 years, working with 80 plus counties, as we look at how do patients arrive to the ED with chest pain in rural settings, 75% show up by private car. They just feel like, multiple things, but we hear, I don't want my neighbors knowing something's going on. I don't want the lights and sirens coming down the street. Oh, no, hey, I live 20 miles outside in the country. I can get there quicker than the ambulance can get to me. And so that's a challenge, because if they're not going to activate 911, then sometimes we just don't have the opportunity to look at what might be available to different than the cost of an ED visit that may not be necessary. So we can put all this in place, but we still have to make sure the public is willing to use the system. Yeah.
And I think that interfacility transport is so important. I mean, Doug, Sandra, any of us that do rural stuff, it can be super terrifying to have 2 rigs and have one team out doing a transfer, for us to Wichita or to Kansas City. And there have been multiple times where a patient stays there overnight or into the next day because we literally do not have the capability to transfer them without leaving our county without any EMS services. So that is super exciting to see something along those lines.
And it goes the other direction too. Patients getting back to their home community sooner.
Which is also super hard coming from Denver or whatever, and families. Yeah, I mean, and you have those ortho patients that families are like, I don't have anything big enough to be able to get this person that just had this hip surgery or whatever home, or that I don't have a car that can reliably get me 5 hours home.
My question is piggybacking kind of on that. Will this also kind of encompass that part of they're not transporting them because they have an emergency? We have a huge issue in our hospital right now where that patient comes in and maybe that nursing home doesn't have the care to transfer them back because they're, immobile or whatever. So they call EMS. EMS has to take them. They're not paid on those. Same thing with that patient who still may live at home and have home caretakers, but they don't have the transportation because of their status to get them to and from. Could this also encompass that? Yeah, the non-emergent transfers to and from the hospital situation and to and from the doctor's office if they're living at home but don't have the capabilities to walk or things like that.
Where's that fund? Jody, where did we hide that fund?
I'll have to look.
It's somewhere. So there's a fund we have for, yeah.
Non-emergent transport fund for the sorts of issues you were describing, separate and apart from these sort of, I guess what I call EMS crisis driven.
Okay.
We did keep them as a separate.
Thank you.
I think it would be great. I think this framework is wonderful. And I think if we really want to get to also initiative 1 to chronic care management and chronic condition management, we should also be thinking about community paramedicine since we're training them, but work them into the reimbursement model. I think it can help out with the workforce, which is why KEMS is really excited about it, the EMS Association, and also they'd be working under a doctor-led team and helping bring down costs. So I think it really makes sense to add mobile integrated health community paramedic components to this bucket.
The one challenge we have there is throughout the notice of funding award and throughout more very directly in the FAQs, you have to have a plan for sustainability. And right now today, even in the state of Missouri, where they have one of the most active community paramedicine programs in the nation, the folks who are writing those checks right now to reimburse for that have been very honest at HRSA meetings and elsewhere that they have no plan for sustainability right now. And so I think there's, certainly the potential as we introduce the concept of mobile integrated care into the plan as things perhaps develop nationally, there'd be the opportunity to add that in, but it would be very difficult for us to try and demonstrate a sustainability model under the current realities.
And maybe there's some misunderstanding. I think in Missouri, they're actually having success working with the MCOs and leveraging PIPs to get reimbursement. So I think there's also, the fee for service model that other states are exploring. So I think there's mechanisms to get to that sustainability. So I think unless we start trying, we won't get there over 5 years. So
we built some components of that potentially in the Medicaid alternative payment model component, because we've got to have some sort of a revenue model in order to be able to demonstrate sustainability. So that is something that we're still having conversations with the MCOs around. But we didn't put it in as its own very specific initiative because there would be an expectation in the plan to clearly define how are you going to sustain it after year 5. It's a balancing act of things we'd like to do and things that we just don't have a revenue stream to support now.
To that last column, the Medicaid APM, one of the requirements of this grant is that you have a vehicle for taking lessons learned and successes realized and transforming that into policy. And so particularly through creating vehicles within the Medicaid program to reimburse new types of services, such as integrated care and food as medicine and community paramedicine, as those are demonstrated up, that there be a vehicle to incorporate that into our existing Medicaid program. There's a lot of pencil right there right now. We have a lot to figure out in terms of how you navigate the relationship between the state and the MCO and imposing those types of alternative payments, but we will at least have a starting point there.
And this is kind of a unique topic, but direct primary care for rural communities, which takes the insurance company out of care. I think it's just worth something to talk about. It's not for everyone, but there are probably some rural communities that might benefit from having some assistance in transforming some clinics like that. So I don't know exactly
Absolutely.
much, but it's something to think about.
Well, we have the element of direct to employer, and that could certainly
Exactly.
be,
It's kind of like that, but it still
It'd be a
opens it up to
subset.
those uninsured patients who fall in the gaps between Medicaid and traditional health insurance, which we really haven't really talked too much about in this discussion yet. So.
Just real quick on the behavioral health crisis transport, similar to the idea of treat in place, we have a network of mobile crisis response units that are already within our CCBHCs. And just curious if it includes an element of that where the mobile crisis response could be going out, but then have the crisis transport with them to either provide therapy right there in place or transport. And that's one of the ways we're planning to solve that if we find a way to do it.
Certainly those could be incorporated, the two. Every time we can braid anything together, we will, absolutely. And that's, again, the value of the Alliance is bringing those resources together, having these types of conversations. So as these projects are launched, there are opportunities for greater efficiency.
And this is Janet Stanek. I just think my comment probably goes without saying, this isn't going to supplant or stop any other work we're going to do in Medicaid or anything. So some of the ideas that we might not adopt through this could still percolate and be worked on. This application is so restrictive on what can be spent and how much we can get in it, which has kind of been emphasized. And if you read it, it's a little overwhelming, but it doesn't mean we're just going to say everything now. KDHE, KDADS is shifted to this, and that's all we're going to do. So David, kind of into your point with paramedicine and other programs that are mentioned that we might not fully adopt, there's still opportunity for us to continue to work on them. Probably goes without saying, but I just wanted to emphasize that. Thank you.
Shall we do initiative 5? Sheena says we should do initiative 5. Okay. So I said at the beginning, there's a very strong emphasis in this NOFO that technology will be the vehicle for transformation for rural health. Agree or not agree, but that presenting a strong plan for the integration of technology in your overall transformation plan is critical. So beginning with specialist virtual visits and care coordination, getting specifically to telehealth. This takes some lessons learned through a series of grants that simply expecting a primary care provider to turn on the machine and have a specialist appear on the other side is not a realistic approach. And instead, developing up a team of specialists who are dedicated a certain percentage of their time to doing telehealth for rural communities, develop relationships with the rural providers, and are scheduled through a centralized care coordination team. We know does a far better job in getting those services directly into the communities. So these are dollars to complement prior funding and recent funding to expand that model further out. So it's for the purposes of hiring and those dedicated specialists, but also critically important, those care coordinators who actually go out to the rural sites, work hand in hand with rural providers, present the cases, track any types of follow-up care. Importantly, the ancillary services that are furnished along with that specialist care, so it generates new revenue into the rural hospitals as well. That model. Number
Marty.
two, yes.
So I just want to emphasize on that. I mean, we had, you can imagine, once this funding came out or was announced, there are a lot of companies out there that reached out and submitted ideas. And I just, this is going to be Kansas centered, Kansas focused. Makes no sense that we're using virtual specialists from Maryland if we can't send that patient directly to them and take care of that care. Plus, there's another number of issues between licensing, credentialing, paying into healthcare stabilization fund, and such, that it just makes no sense that we need to go outside of the state boundary to find that specialist.
Number two, inpatient and post-discharge remote patient monitoring, leveraging new technology on the market, wearables that an individual can wear while an inpatient at a facility, taking continuous vital signs, as opposed to having a nurse take anecdotal vital signs. The information from the devices feed to a centralized monitoring center, and that center is staffed with clinicians, primarily nursing staff, that they can coordinate it back to the facility for appropriate intervention. Early research with these wearable devices are showing a number of benefits, reducing staffing needs in the facilities that utilize them, seeing shorter lengths of stay, shorter complication factors and the like. So introducing this first at the anchor hospitals with higher inpatient volumes, and then as the program expands on, seeing those opportunities to utilize it in additional settings. Also using it post-discharge, so as a patient leaves a facility, to reduce the risk of readmission, that you continue wearing the monitoring device at home for a period of time. Again, that data feeding into a centralized center, and then the intervention is necessary with that patient in their home. Questions? Okay. Data infrastructure. Just a number of initiatives intended to get our arms around data, both for reporting purposes, but also for development projects. And these range from creating data centers for the community mental health centers, I'm not going to explain this very well, but a use of a diabetes doc, so that you sort of the dream we had back in the initial days of HIE, that data from multiple sources could be flowing in to a centralized location, then be able to manage that patient appropriately based on that data. We have early work going on that with pediatric diabetes cases, using that in the initial early stages to develop fully the protocols and processes, and be able then to extend it on to other conditions where that immediate data accessibility is necessary. The continuation of the all payers claims database. Kansas is one of the early adopters of all claims databases, but certainly there are opportunities to enhance that significantly, make the data more broadly available and more immediately available. And then HIE rural connectivity. Again, it's a highlight in the NOFO of ensuring that all providers have connectivity to an HIE and utilize that HIE effectively. So not only would this be dollars to connect the last remaining rural providers, but also providing opportunities for enhancing the use of HIE information in direct patient care and follow-up. Oh, the Emerging Technologies Fund. This is both focused on patient-facing tech, again, that key factor, as well as artificial intelligence. And on both, it is an idea of convening an expert panel that can review products in the market as they come to market in both of those areas, effectively provide a good housekeeping seal to those products that could be effectively utilized in different practice settings. That same expert team developing implementation support for providers. So how do you integrate this piece of AI into your revenue cycle, for example? And then, of course, providing the dollars for acquisition of those products is appropriate to organizations that need those financial supports. I cannot see the last slide. Oh, and this EMR implementation and support. There is a very limiting restriction on replacement EHRs. You can only spend 5% of total monies on that. But those opportunities, as providers identify need for optimization of their existing EHR, providing a vehicle for funding those opportunities as well. Questions on the data-driven initiative, data tech-driven initiative?
Couple things. First off, I have experience using a technology that we would have from a primary care physician asking a specialist to review a case called Rubicon. And then the specialist would review the case. We would communicate with each other and then decide whether or not it would need to be referred to a specialist. I think that might be something that would be helpful for rural physicians to have that access to. Secondly,
specialist.
Yeah, I think it would be that first box. The second thing is the all-payer claims database is an important part of evaluating primary care investment numbers in Kansas. It's something that we've talked about from the family physician standpoint. For every dollar you save, or for every dollar you spend in primary care, you save $13 in total cost of care, which it comes down to a simple numbers game, but it's hard to convince that process to get enforced into policy, I guess, so to speak. And so it's something that if we could include that in some of the plans, that would be wonderful.
Absolutely.
I did have a question, and to piggyback on that about the all-payer claims database. So historically, that does not include self-insured data, for example. Is any part of the proposal, or could it be part of a proposal to advocate for, create a campaign to increase voluntary contribution to the
Incentivize.
Yeah, is that part of the proposal?
Part of it would be feeding back the data to, if you contribute the data, you have access to the data. Clearly, if you're self-funded, you have a critical need to understand the spend. And so that's would be the advantage to you. No, self-funded.
Self-funded.
Yeah, the current Kansas statute does not, because ERISA funded plans are not subject to the claims database. So they have to voluntarily report. Self-insured. I always call them ERISAs, so same thing. I think they're the same thing. Yeah, I'm sorry.
So to the point about Rubicon, there are, as I understand it, probably several different existing technologies right now. Another one is called Coltrane that would connect specialists with primary care physicians, and they're Kansas-based. So did they have to already submit to be a part of this proposal, or could there be a variety of providers for that that technology under this plan?
The beauty of building it together is as we get the dollars and understand the current landscape. If I was doing a planning process, right, I'd want to understand the current landscape, understand all the available resources. But we're going to plan after we get the money, apparently. And so certainly as part of that process, we'd want to bring all of that in. I mean, the goal here is not to have winners and losers. It's the only losers are going to be those that we just don't appreciate and acknowledge and be able to bring into the whole process. So yes, absolutely. Keep that open as much as we can. And thanks for keep advocating in that regard, because it's something we have to remember is, yes, we have the proposals that were submitted, but we know there's so many more rich resources available in Kansas that we need to leverage to the fullest extent possible.
Yeah, and I guess I would just go on further to say I was concerned if it had to be a new, if there's already existing resources and we can enhance those and provide them and connect them, because we'll get to it later, but we have wonderful HIE resources in Kansas that are already connecting most hospitals. So there might be a way to direct that into private practices who need to update or integrate. But most of them are already connected and really into one that's Kansas based. And so I want to make sure we consider that as well.
That is exactly the purpose of these additional dollars, is to get the rural providers, clinics, other types of providers on the HIE, and then to optimize connectivity for all of those providers. Okay, breakout time. I'm not, oh, questions? Or we can just look at each other for a minute. Or I could be typing.
All right, so now we'll have some time at your tables again. So stay at your tables. Bring out your discussion guide again, and you will discuss at your tables the questions that are on there for initiatives 3, 4, and 5. Members of the CARE Collaborative, the application team, will be walking around. Raise your hand if you have a question for them. And KHI facilitators will also be walking around, so we can grab them if you need to assist in your discussions. So please begin. All right. Okay, so we're gonna share out for the initiatives 3 through 5. We're gonna begin with 3, and given the time constraints, we have about 10 minutes for share out, so we'll have about 5 minutes to share for each. We'll just take some volunteers. So for initiative 3 related to workforce, do we have any volunteers to share what you discussed at your table? Priorities to include that have the potential to be most transformative, anything missing, any other considerations? Thank you, Greg.
Yeah, I'll go. In our conversation, you just talked about things that would be truly transformational would be the rural residency programs. And with that would come some housing assistance for the med students that are rotating. But one of the challenges that we would have is getting boots on the ground psychiatrists present in a rural setting to be able to help with that residency training program. That's the biggest challenge that I see. I'd love to have that, and I would support that, and I'd provide some housing. Just bring me a psychiatrist, for crying out loud.
Thank you. Any other comments from other tables about workforce?
Just to piggyback on that, we talked about expanding that housing assistance to all healthcare, behavioral health, not just an MD level, because that is still a concern if you try to do any kind of rotations out in rural.
So expanding to all. Thanks, Wyatt.
There's a clarifying FAQ that limits the support. I'm sorry. There's a clarifying FAQ that came out Friday that said we're limited to 6 months. So, but that should be workable, right? Okay.
Okay. Back here.
Okay, we talked.
Sorry.
We talked about this as it started as a joke, but it's not really a joke. We talked about matchmaking programs because really it's why a lot of people don't stay in a rural area, even if they go there.
Oh, okay. I'm tracking now. Literal matchmaking programs. I was thinking about employers and providers, but I got you. Okay, add it to the list. Is that the most transformative idea we've had today? Maybe.
I was going to say that with the rural residency programs, I think it's really important to keep in mind that like one of the reasons that I went to Wesley was because I knew I was going to go out and serve rural, and I needed to make sure that I had seen absolutely everything I possibly could have to go out and properly serve my community. So if you're talking about this and you start getting down to the lowest, like to smaller and smaller levels, you are going to have difficulty not only meeting ACGME guidelines for like the number of patients you need to have for procedures you've done and for experiences you've had in specialty clinics, but you're going to have some difficulty just having doctors come out who are like really properly trained. So the idea of starting at a larger area and then having like remote rural locations for the last year or for parts of the year or something, I think that's really exciting. But also if you've ever done any residency and academia kind of stuff, having a program director, and Dr. Moj and I were talking about this, having faculty that's able to do that, it's freaking rough. So I think you'd be looking more at like a larger residency with then possibly some experiences here, and then having those experiences to go out to the smaller place as opposed to a smaller town being like the head or the hub of the residency.
And Beth, to piggyback on that, you and I know that after we went to our rural residency program, then we joined partners who mentored us for another 5 to 8 years until we actually felt comfortable. So it's really important to have mentorship in those physicians who finish residency as well.
Thank you. All right, there's an opportunity to continue to take notes, and we'll collect all of the feedback we receive for Initiative 3, but I'll move us on to talking about Initiative 4, enable value-based care. Who wants to go first?
My comment is the key foundational thing for value-based care to be successful is actually in the contracting. And no matter how much preparation, how much investment you put in, if you don't have good contracts between those who are providing the care, the providers and the payers, it will not work.
Thank you. All right. Any ideas about what felt most transformative under Initiative 4?
I guess one thought I had, and this might tie into 3 as well in terms of retention and recruitment, is with the evidence-based practice incentives, ensuring that we're not just looking at nurses, physicians, but what else do we need in our community for it to run as far as healthcare? I know one thing we struggle with is dentists and pharmacies. We have 2 dentists in a small rural community, and only one of them provides care services. And so if that dentist is overworked and no longer accepting patients, which I believe they are, it'll be at least an hour drive for them to go somewhere else that probably accepts care. So and I know that we are very fortunate in our area to have a dentist that provides care services or Medicaid services as a dentist, and I know a lot of people don't. So in my mind, I'm thinking, what are things that we're missing or that we really need to fill those gaps? And I know rural pharmacies get it kind of tough at times, and I know rural dentists get it pretty tough. So thinking about those aspects as well.
Thank you. All right. Any other thoughts for Initiative 4? Okay. Moving on to Initiative 5, harness data and technology. Anyone want to summarize the discussion? I'm okay with silence.
Yeah, one of the things we talked about a lot was talking about inpatient post-discharge remote monitoring, and not only keeping it at that level, but also some of the preventative monitoring you can do with things that are available today. And so it might not just be necessarily directed at 30-day readmits and those kind of things, but really about finding folks that have chronic needs and managing them through that's interim.
Thanks, Aaron.
So I guess this did bring up the question there was kind of a list of different vendors that appeared, kind of a broader question of, are we actually selecting vendors or are these just examples? And I guess just a personal question, where do I apply to get this funding to pay for my clinic's AI scribe? Because I would love to have somebody pay for that.
So the NOFO does ask for us to list vendors where we can. And, but we also know that we didn't have a huge amount of time to be able to go through this process. So you saw that we listed Oracle AI. That is strictly because 50% of rural hospitals and their associated clinics in the state of Kansas all use Cerner Community Health Works. And so Great Plains Health Alliance and others have a really straightforward process for just being able to implement AI in those specific folks. And that represents about 50%. And then you saw it also included a technology fund. And the thought was that we would get subject matter experts together and be able to entertain just those sorts of options, making sure they meet with the federal requirements around certifications and all of that. That's why we'd get a group of subject matter experts to help guide the fund. But yes, it would be just for those sorts of opportunities. So whatever AI supports your version of an EHR or may connect now, you've got it in for ambient listening, but you want to add the new coding module or, et cetera, there would be a fund that you could submit to be able to get that funding. We used Oracle just to meet that expectation in the application that wherever possible, we list vendors.
Yeah, I checked. Oracle is not ours, so.
Yeah. It seems as though, as I'm told, and I am far from the subject matter expert on this, but as I talk with folks that are, it seems as though different EHRs have differing AIs that work better within them. Epic has one sort of AI, Meditech another, et cetera. And so it's hard to say one size fits all. And that's why we thought where we know one size fits all because they're all on the same platform, let's list it. And where one size doesn't fit all, let's have a fund.
Okay. All right. Any other thoughts related to Initiative 5? Okay. So now we're going to have a few minutes. We can give you an opportunity to walk off your lunch a little bit. So we're going to do an activity together. So you all have packets of dots at your tables. You'll notice that the initiatives are numbered beginning on the back corner, 1, 2, 3, 4, 5. We've captured notes related to the programs and projects that are included under each initiative. So what we're going to ask you to do is walk around to each of the initiatives. You'll have 3 dots per initiative, 15 total. And you are invited to place up to 3 dots per initiative for the programs or projects that you feel have the potential to be the most transformative for Kansas. So we'll have a few minutes to do that. So I invite you to get up, and now that you've heard the discussion, the feedback, the questions around the initiatives, please go ahead and do so. And if you think a priority is to answer a question, you can put it next to that too.
Thank you for dotting. It's very helpful. It's good to see this visually. Good news. At some point in November or December, yet to be determined, we will do another webinar for the general public, but of course, encourage the Alliance members to participate, that will actually walk through the final submission to CMS. We will certainly preface any presentation by saying that we are still in the negotiating period with CMS, that not every project may make it through to the end, but this is what was in fact submitted. So we want to, again, remain as transparent as possible throughout this process. We are simply just working within very difficult time constraints. One of those constraints with which we are working is letters of support. The application only requires a letter from the governor stating that she supports the plan as presented in the project narrative and supporting documents. And Secretary Stanek and Secretary Howard promised me that she's going to sign that document. Yes, she has the draft, so that's excellent. But we are encouraged to submit other letters of support in our supplemental materials. So it's 60 pages double spaced for the project narrative, 20 pages single spaced for the budget narrative, and 30 pages of supplemental materials. Now we need a significant portion of those supplemental materials to include the Gantt charts that will show the milestones and implementation strategy. If you look at all of the projects and programs along the walls here, we have to explain on a quarter by quarter basis to CMS how this will be implemented. So you can anticipate that's probably 20 pages. We also have to submit a 4-page document that is the list of all CCBHCs in the state of Kansas with all of their locations. That's part of the rural factor scoring that we need points for. So rather than asking each of you to submit a letter of support, we have drafted for your consideration an alliance letter of support. I left these on your desks as you were dotting along. It is relatively general in that it explains the process that you all went through as the Alliance. For those of you that have been with us the entire way, you have given us an entire day of your time between the 3 meetings, and we are so very appreciative of that. That is not to include the meeting several of you had with Jody and Dr. Mosier one-on-one to talk about your initiatives and your viewpoints on this. All of that stakeholder engagement is critical. It is part of the scoring rubric for CMS. There's an entire section to be drafted called stakeholder engagement before, during, and after. So we are very appreciative of our ability now to present a very strong case in terms of the level of engagement we've had. But we would like you all to review the letter. KHI folks have so generously just volunteered to help us with securing your signatures through an online system that I don't even begin to understand, but that's okay. But we'll get your signatures on the letter. The reason we need to compile them into a single document, there's some great stories of submitting multiple signatures on a single letter of support and CMS saying, no, that's not 2 pages, that's 36 pages. Each signature should have been counted separately. But we won't go through that. Not that I'm bitter. Okay, anyway. So what happens now? Well, let's say what happens in January. We've made it through the negotiation process. CMS promises by the stroke of midnight on I guess it'd be January 1st if it's the stroke of midnight of 2026 that it will award first year funding. And so now we move into the implementation phase. And part of what we have to include in the application is an explanation of the governance and management process to the extent that has been stood up. In this room with us today is the program manager for the Rural Health Transformation Fund, Secretary Stanek. She will have assistance through state agencies in support, particularly of tracking expenditures. So all dollars expended by this fund will have state approval. There'll be recommendations made to the state, but all final decisions on funding, any expenditure of these dollars will be made by the state of Kansas, as will the approval of any final work plans. At this point, we are working on an agreement between the state and the CARE Collaborative to provide the ongoing project management services. So to make sure the trains run on time, the implementation plans are adhered to, that there's ongoing conversation with the CMS project officers as well. So that kind of keep everything moving project management rather than bringing an external consultant out to do that, using the team you now are all too well familiar with, working forward on that project. That is not to say that there will not be many others involved. Particularly workforce, for example, leading on HealthWorks expertise and experience in this area, certainly that they would be a subcontractor as part of the project management around those initiatives. We've talked about the funds and I'm surprised none of you asked, but who's going to decide who gets what money on the funds? That is because our dear friends at Grant Makers in Health have so graciously offered to use their expertise. They don't know, all of them don't know that you volunteered, Ed, but I'm telling them now, okay? But to use their expertise because they are professionals in developing scopes of work, convening the appropriate experts to review those, to balance competing interests, but certainly we don't want to reinvent the wheel. And that affords us the opportunity. When we talk about convening experts around AI and patient-facing technologies, again, expertise is the Kansas Hospital Association that we can draw on to serve as those conveners and the like. So we'll be looking, of course, across those opportunities. It's all, more hands make lighter work for everyone. And that is, and also just the level of engagement we want throughout the state through all of this implementation. But there will be consequences. And we've just had this conversation during lunch, is that there's so many times we have grant monies that make it to folks' hands, but the work never gets done. whatever it may be, is that we award dollars and we don't see the progress we hope for. So as is CMS holding the state accountable for meeting certain metrics, we will build in to awards of dollars to provider organizations and other types of entities very specific performance standards and the expectation that they meet those standards and a willingness to claw back when we don't see the level of progress we want. So we will have a very high degree of accountability throughout this process. Jody and Dr. Mosier, anything to add to that? Why they trust me with the mic, I have no idea, but they have for so long. So I'm going to turn this back to the secretaries to take us home.
Okay, and I think Marty covered a lot of what we were just going to close with. Thanks for continuing to inform the development of the application with the measurable criteria and so forth yet to come. I would say, as she described, a high level outline of what our vision is for the future governance of this, if we get the money, when we get the money. This alliance will continue to play a key role in that. I just want to reiterate that. Again, the detail of the different components will be worked out, and we're working with the governor's office on that right now, but we'll be making sure that it meets the requirements of the federal government, as well as making sure that all voices in the state are heard and understood. So I just want to again say thank you. Please stay tuned for the next series of meetings that are going to be coming up between now and the 24th, when we finalize the narrative, and then be ready to hit that button on November 3rd, which is right around the corner. I'll turn it over to Secretary Howard for closing remarks as well.
Thank you. Yeah, thanks for your attention today. It was a long, full day, lots of details, great questions, great conversation, and the work today will make the application better and stronger. So thank you for that. And as the Secretary said, you're not off the hook yet. The Alliance will continue. So, so again, if you thought you were going to kind of walk out this door and be off the hook, and unless maybe some dollars came your way, we're not going to let you go that easily. We really value your insight, your knowledge, your expertise. It will not only will make the application better, it will make the absolute program better as we receive funding from the federal government and begin to implement the transformation in Kansas. So thank you. I think that's it. Goodbye, everybody. I guess Sheena. I guess I should go back to Sheena to do the formal closing. I didn't see you there. I thought you.
No, it's okay. Just a reminder to turn in your notes to one of the facilitators here, or leave them on your tables. We'll collect them. If you have any other dots, place them up on the wall. Thank you so much for your time today. We really appreciate it. Have a great afternoon.